Dear colleague Magdy من وحدة أمراض نقص المناعة will present pulmonary disease in inborn errors of immunity. مفيش حاجة اسمها congenital immune deficiency. This term does not exist and has never existed. The old nomenclature كان primary immune deficiency ودلوقتي اسمه inborn errors of immunity IEI. May please.
Thank you. Thank you, Dr. Aisha. Good evening, everyone. Today we will navigate through the pulmonary disease in inborn errors of immunity. Okay, we will overview the lung immune connection, the mechanism of involvement, clinical presentation, diagnostic approach, and management. Of course, the lung is a main target organ in patients with inborn error of immunity. The mechanism of involvement is through recurrent infection, which is the most common known mechanism. However, immune dysregulation, autoimmunity, and interstitial lung disease are also important mechanisms of pulmonary involvement. Okay, we will discuss the disease pattern of the pulmonary manifestations in patients with IEI. We will start with the airway disease. The recurrent infection causing mucus plug in the small airways, causing something called tree in pod that is seen, as you can see, in the high-resolution CT image. As the disease go on and the infection continued, neutrophilic infiltration developed and the patient developed bronchiectasis. Airway compromise can also result in bronchiolitis obliterans. The most common pathogen for bronchiolitis obliterans is the adenovirus. However, it can occur also post bone marrow transplantation. It's a non-reversible airflow obstruction, which is important to distinguish it from the asthma, which is sometimes one of the presentation in our patients. In lung imaging, as you can see, regional air trapping with mosaic attenuation is seen in both inspiratory and expiratory high-resolution CT scans. Alveolar disease pattern, it's typically present in the form of pulmonary consolidation or ground glass appearance. However, the ground glass appearance is non-specific to the patient with inborn errors of immunity. It can be a non-infectious cause for the ground glass appearance, as in alveolar proteinosis and diffuse alveolar hemorrhage, or infectious causes as the opportunistic infections such as Pneumocystis jirovecii and cytomegalovirus pneumonia. Regarding the interstitial pattern, interstitial lung disease and interstitial pneumonitis is an umbrella term that describe the diffuse involvement of the lung parenchyma. It can be reticular, nodular, or reticular-nodular pattern, as you can see here. One of the most important examples of the reticular-nodular pattern in patients with CVID is the granulomatous lymphocytic interstitial lung disease, which is a non-infectious complication in the CVID. In 2017, the British Lung Foundation and the United Kingdom Primary Immunodeficiency Network defined it's called GLILD, by the way, also granulomatous lymphocytic ILD, which is a distinct clinical, radio-pathological interstitial lung disease occurring in patients with CVID, associated with a lymphocytic infiltrate plus or minus granuloma of the lung, and in whom other conditions have been considered and where possible excluded. The granulomatous ILD is also associated with autoimmune features, which is important also for the definition of the granulomatous ILD, such as splenomegaly and cytopenias. As you can see in this cut, there is splenomegaly and lymphadenopathy as well. Typical features on the CT include solid and subsolid nodules, ground glass, and reticulation. In the pulmonary function tests, both obstructive and restrictive patterns were reported. So, should we proceed to lung biopsy? It's still a debate. When to think of what are the indications for lung biopsy in patients with GLILD? Diagnostic uncertainty or suspicion of malignancy. Biopsy can either be endoscopic, transbronchial, or percutaneous, either by surgery or CT needle biopsy. There are the abnormal histological features that suggest the diagnosis of granulomatous ILD, either granulomas, lymphoid interstitial pneumonitis and organizing pneumonia, lymphoid hyperplasia, interstitial fibrosis, and follicular bronchiolitis. Okay, regarding the pleural compartment, it can be either infectious as a part of the pulmonary disease or non-infectious in patients with autoinflammation, systemic autoimmune, and immune dysregulation. Regarding the vascular compartment, it has two keys: diffuse alveolar hemorrhage and pulmonary hypertension, which occur in patients with systemic vasculitis due to either autoimmune or autoinflammatory process. Okay, regarding the identification of the lung disease pattern in IEI patients, as you can see in this figure, the most common part of the lung affected in patients with combined immunodeficiencies are the airway, with bronchiectasis as the most common manifestations in those patients. Interstitium is also affected, but of course it's more or less than the airways. In patient with, as you can see, in patients with predominantly antibody deficiencies, the airways are the most affected part, with bronchiectasis in almost all the patients with antibody deficiency. However, in patients with immune dysregulation, as you can see, interstitium is affected more than the airways, which can be caused either by infection or due to inflammation and autoimmunity associated with patient of immune dysregulation. Okay, regarding the diagnostic approach, when a patient with pulmonary manifestation is suspected to have inborn error of immunity, there are some red flags that raise this suspicion. As you can see, recurrent infections, atypical pathogens, immune dysregulation, family history, either consanguinity, infection, sibling deaths, malignancies, autoimmunity. Then, if we suspect that this patient has inborn error of immunity, the next step is the diagnostic workup through pathogen isolation, and as we said, atypical pathogens should suggest more that the patient has inborn error of immunity, as we will mention later. Pulmonary function tests and imaging are very important in the diagnosis. High-resolution CT is the standard modality for investigating lung disease pattern in patients with inborn errors of immunity. Bronchoscopy and biopsy are only when indicated. Not all the patients need biopsy. Then we will proceed to immunological testing, the basic immune profile. If all this didn't help us to reach a diagnosis, sometimes we need to proceed to genetic testing. Multidisciplinary collaboration is very important for the diagnosis as well as the management, and that we will discuss this later. Okay, here there are some warning signs, clinical signs, for pulmonologists to think about inborn errors of immunity. Pneumonias with extracellular bacteria, pneumonias with mycobacterium, recurrent fungal infection, nematoceles. And those are the specific pathogens that could be seen in patients with inborn errors of immunity. As you can see, intracellular bacteria, BCG complications are very common in patients with T-cell deficiencies, as well as Pneumocystis jirovecii. In patients with antibody deficiency, encapsulated organisms are the most common organisms. Patients with vacocytic disorder, Candida, Aspergillus, fungal infection, as well as Mycobacterium are very common. For the patients with complement deficiencies, encapsulated organisms are very common pathogen. Regarding the management strategies, infection prevention and treatment through antibiotic prophylaxis. Antifungal and antiviral therapies are given to specific patients. Not all the patients need antifungal and antiviral. It depends on the disease and the state of the patient. Immunomodulatory therapies, immunoglobulin replacement therapy, IVIG or subcutaneous immunoglobulins, corticosteroids and other immunosuppressants in cases of non-infectious complications. Advanced therapy as the bone marrow transplantation in case of patients with severe inborn errors or the patient who can proceed to bone marrow transplant. Gene therapy, it's an emerging option, however, it's not available now. Targeted biologicals. regarding the supportive care, pulmonology rehabilitation, and management of complications in the form of bronchiectasis or chronic lung disease. Long-term follow-up is very important through annual pulmonary function for the follow-up of the lung functions of the patient and the development of the disease and any other complication, as well as high-resolution CT that should be done every 2 to 5 years. Regarding the treatment of the granulomatous lymphocytic ILD, the most important and sometimes the only therapy is immunoglobulin replacement therapy. However, in those patients, higher doses are needed, which may reach to 600 to 1.2 grams, 600 milligrams or 1.2 grams per kg per dose, which is higher than the regular IVIG doses we give to the other immune deficiency patient. Immune suppressive treatment is only needed if the patient has persistent symptoms or progressive lung disease, starting with the corticosteroids. Then if there's any problems with the steroids or we need to spare steroids, so we shift to azathioprine or MMF. And the last option is rituximab in very severe cases, and it can be done as monotherapy. Regarding the multidisciplinary approach to the diagnosis and management, clinicians with expertise in diagnosing and managing inborn errors of immunity should work in a concert to develop diagnostic and care plans for these patients. Seeing patients in the same space at the same times help to develop disease-specific plans and optimize communication between specialties. Teams managing patients with complex immunologic disease often require the involvement of many specialties, such as genetics, radiology, specialists in the care of the organ-specific complications, such as the gastroenterologist or hematologists, and in some time, oncologists and bone marrow transplant services are needed. For the recap, early diagnosis and intervention are crucial. Widen the spectrum of the lung involvement in inborn errors of immunity. It's not just infections. High-resolution CT and pathogen isolation is crucial. Multidisciplinary care plan is very important for proper management of the patient. Thank you so much.
Thank you, May. Thank you for a lovely presentation, and thank you for sticking with the time. And please allow us to introduce آخر حد جويند العيادة عندنا وإحنا سعداء بوجودها معانا سوسنة. هي هتقول لنا case presentation showing pulmonary manifestations في ال IAI.
أنا هستأذن حضرتك يا دكتور، أنا هرد بس على الكويستشن بتاع دكتور كريستين في مينت بالظبط. احنا عاينين السي جي دي ليهم وايد رينج من البرزنتيشن، الايج برزنتيشن، ممكن من اول شهر لحد ما يبقى 20s وساعات 30s كمان، ووايد رينج للبرزنتيشن ككلينيكال برزنتيشن مانيفستيشنز. يعني ممكن من مجرد اورال مونيليزز وجرانيولومز لليفر ابسيسيز وميليار تي بي وبرين ابسس كمان. this patient هو كان جاي فعلا وهو عنده 10 سنين، بس هو كان عنده هيستوري قبل كده ان مامته بتقول ان في ازماتيك اتاكس، فممكن جدا دي ما تكونش ازماتيك اتاكس، بالذات لما ولاد كان جاي ستونتد جدا. كلابينج، الكلابينج ممكن يحصل لو هو بقاله سنتين، لكن هو فعلا كان ستونتد جدا، وكان البيرنتس شايفين ان هو شورت كمان. يعني ده كان من احد المشاكل اللي هم كانوا جايين بيها اصلا. فبس انا حبيت بس اوضح النقطه دي. ميرسي يا دكتور، ثانك يو.
وكمان كان عنده باستيولوزيس وهو عنده سنتين، ودي ما تتعداش. وطبعا انا اول ما بلاقي اسبرجيلس انا خلاص شخصت، وهو غالبا من الصعيد.
مش فاكره
ما والسكند كويستشن، السؤال الثاني اللي هو او يعني تكمله السؤال بتاعك، لو حضراتكم شفتوا الدي اتش ار تيست بتاعه هو طلع 47. احنا عموما السي جي دي الدي اتش ار تيست الستيميوليشن اندكس بيطلع قرب الزيرو، يطلع 1 نص 3، انما 47 ده اقرب للنورمال، وده اللي احنا بنشوفه في البي 47. عشان كده هم بيبقى عندهم residual function للنات بي اتش اوكسيديز، فعشان كده بتبقى الايدج اوف برزنتيشن بيبقى متاخر شويه في العيانين البي 47 لكن الاميون ديسريجوليشن يعني اللي هو المانيفستيشنز نوت ديو تو انفكشنز في السي جي دي بتبقى اكتر في عيانين البي 47.
Thank you دكتور عائشة for the
keratoconjunctivitis يحصل لهم iridocyclitis اوتو اميون بتبان مانيفستيشنز فيهم اكتر، وهم عشان كده كل السي جي دي لما بيكونوا عندنا بنديهم انتي بايوتيك، ولما بيبقوا تعبانين قوي لازم ياخدوا ستيرويدز بس ما يزيدوش عن 1 ملي جرام بير كيلوجرام واندر امبريلا اوف انتي بايوتكس.
Thank you دكتور عائشة for the حضرتك قدمتيني